We are Project SCOPE, which stands for Supporting Children of the Opioid Epidemic. We focus on providing education and professional development on the topic of neonatal abstinence syndrome and neonatal opioid withdrawal syndrome, or NOWS. We are a community of early intervention providers supporting children and families. And I believe all of us are in Minnesota, and we use the ECHO virtual training model. Next slide. And a few components of ECHO stands for Extension for Community Health Outcomes. And it's really an everyone teach, everyone learn model. So while we have an expert presenter, such as Dr. Lynne Katz today, we also have a time where we do a case study and we hear from practitioners and early interventionists out in the field and learn from your knowledge and expertise as well. We work to promote health equity and educational equity, and we really want to reduce disparities and increase access and really bridge health and education. And again, we're a community of practice, so please feel free to share your experience as well. We're lucky you can do it verbally or in chat. Next slide. And again, the four principles, since we technically are an ECHO model, we use technology. So here we are over Zoom. What we do is research-based and embedded in best practices. We always have a family story, or as the medical field calls it, case study, but we say family story, right? Because we work with families and we use data to monitor outcomes. Please fill out your survey. We really, really appreciate it. And we need it for our information as well as to who's attending, but as well as how we can even provide more professional development for you that is of interest. So thank you for filling that out. Next slide. So we're in session 5 today, supporting children with the opioid epidemic with continuity of care. We're very happy to have Dr. Lynne Katz with us here today. She's returning and we really loved her presentation. Dr. Lynne Katz is a retired research associate professor in the departments of psychology and pediatrics. Thanks, Drake. I skipped a slide. At the University of Miami. She was the director of the university's Linda Ray Intervention Center for high-risk children ages 0 to 3, who were born prenatally drug exposed and were victims of child maltreatment. Since 1993, she coordinated the program's comprehensive early intervention services for over 1,000 infants and toddlers and their families. She was the early childhood partner who assisted in the development and ongoing implementation of Miami's dependency drug court services for children and parenting, and has worked extensively with NDCI, what training of new family drug courts. What is NDCI? I don't know what that acronym is.
The National Drug Court Institute.
Oh, okay, great. Thank
you. Policy out in Las Vegas, Nevada.
Thank you so much. Well, Dr. Katz, thank you. Welcome. We are happy to have you, and we look forward to your presentation. And Drake, since I skipped over the schedule slide, can you remind me again how long Dr. Katz has? All right, yeah. You have until about 3:50, so you have plenty of time. We don't want to rush you. And I'm right on time. It's 3:05. So thank you.
Okay, thank you so much, Dr. Hall-Lande. Pleasure to be here. Pleasure to be with all of you today. And as that first picture showed, I have been in Minnesota. I have worn a jacket. And yes, about just before COVID, we did some work with what's called the Guardian Ad Litem program in St. Paul and that area. So we had the pleasure of coming out, and there, who could beat being with Snoopy and the whole gang there of Charles Schultz. So I feel a real affinity being with you all here today. I won't tell you what the temperature is here in Miami. Why bother? Let's not go there. Okay. So we're going to talk a little bit today about caring for babies and families that are impacted by opioids. And we're going to talk both the theoretical and also what a practice model has looked like. What is best practice? I know that's one of the bullets for your project. What is the best practice? And we're going to talk about what we've been learning from the field, because there's sort of been a change in attitudes and beliefs about how we should work with those families. So Drake, if you can go to the next slide. So I love to shock everybody by making a statement. There's no such thing as a baby. I love that statement. It's actually a quote from a very famous child development scholar in England back in the 1940s. And what did he mean? There's no such thing as a baby. I always like to wait and see if people come up with ideas. But the fact is that a baby exists in her or his relationships. Who are the adults? Who are the siblings around that baby? Because it is in those relationships and that environment where a baby from day one sees themselves reflected and begins to build the kinds of things we always talk about, which is self-concept, self-esteem. Am I meaningful? And does it matter that I'm here? So everything we know as early intervention people, and I've been an early intervention person for longer than most of you have been alive. So I love our field. I love what we do. And I love the fact that we bring to the table, we speak for the baby, as we say. We let people know what children too young to speak are thinking about. And we're going to talk about what that looks like in these high-risk families. Next slide. So we know that as early intervention folks, we know what babies need for healthy development. Consistent, sensitive, reliable responses to their needs from the folks, the caregivers around them. Their growth and development is guided and supported by the kinds of interactions that they have with their environment and adults. And those interactions are going to be supportive and help guide, or in some cases, those relationships may stymie the growth of that child, may not understand the developmental period the child is going through and not allow them to pass through that developmental period in a healthy way. So it's also about expectations. The folks around us, what do they expect for us as a baby? Are they happy that we're there? Are we guided and engaged to be challenged as a baby and to try things and then to be nurtured and supported by those around us? Next slide. So why is it important that we understand that babies, that infants exist in relationships? Why do we care? Another famous psychologist, John Bowlby, who we all studied Psychology 101, child development. He first talked about attachment. He talked about kinds of attachment, and that a trusting and secure relationship with at least one caregiver is probably the single most important predictor of a child's future growth and development, not only socially, but data shows that moving forward in terms of intellectual development, social development, at least one caregiver is necessary. Now, I have to tell a quick, funny story. I won't take long. I was doing a presentation and I used a slide similar to this. And at the end of the presentation, a gentleman who was elderly himself came up to me and he said, I'm John Bowlby's grandson. I said, oh, goodness gracious. Oh, goodness gracious. How did I do? What did I say? And he said, no, it's a pleasure to hear you talk. And it's a pleasure to hear that we're still providing that emphasis about the caregiver baby child relationship. And this is particularly relevant when we talk about infants born prenatally opioid exposed, because we're talking about a baby being born into an at-risk situation. And how can we as providers, as early interventionists, as social workers, as guardians of children, how do we keep that important thing going when there are risk factors associated perhaps with the biological family or the biological mother that are going to have to be assessed from the perspective of, can this parent keep this baby safe? Can they provide for their well-being? And can we help support that family, that mother typically, so this can be a long, permanent, positive relationship between the mom and her infant? Next slide. So when we talk about neonatal abstinence syndrome, we know that as the number of infants who are being diagnosed with this in hospitals rises, academic medical centers, pediatricians, psychologists are trying to find new ways to treat the infants and support the mothers and support the relationship. For decades, what we've done is we would use a tool. We're going to talk about the Finnegan tool. We would use a tool if we believe that baby had been exposed to opioids. We're talking 40, 50 years we've been using that. It was the prescribed assessment coming from the Centers for Disease Control and Prevention. And we would look to see if that newborn had signs of drug withdrawal. Next slide. So this is the name of the tool, the Finnegan Neonatal Abstinence Scoring Tool. And it's a rating scale that tries to figure out the degree of severity of the situation for that baby. And very shortly, between 2 and 3 hours after that baby is born, they come up with a score and determine what sort of medication they are going to give that baby to counterbalance what's happened because of the opioid in the mom's system passing through the placenta. Okay, so next slide, thanks, Drake. What has always happened was pediatric wings of hospitals then immediately transferred that baby to the NICU, separated the baby from the mother. And I don't know if you have ever been in a NICU. I don't know with any of you with your own children or seen it on TV on all of these hospital shows, but it's actually a noisy place with beeping machines going on and off, respirators going on and off, people moving and walking and talking, and then alarms going off if something is going on with a baby, in which everybody has to run to that baby's incubator. So what would happen is the baby would be tested on the scale to see to what degree there was a drug withdrawal going on. And then based on that score, standard care was, let's take the baby away from the mom immediately, put them into the stimulating environment of the NICU, and babies would stay there day after day after day, sometimes as long as a month or close to a month. And that was where the pediatricians were able to treat them with methadone or morphine or whatever the drug of choice was. And mom was either back in her hospital room or sent home. And baby was in that NICU, and mom could choose to visit. Some moms do visit a lot. Some moms were so worried and depressed that in fact they did not visit. And so the caregivers, the multiple caregivers and the nurses, shift after shift, were the loving but stranger caregivers in the NICU, caring for the treatment of the baby. And about over 10 years ago, a team of doctors at Yale University School of Medicine said there's got to be a better way, because not only are we disrupting that attachment growth from the very beginning, we may, in fact, this may cause more harm to the baby, not harm like the drug, but the fact that there's inconsistent care. It's quality care, don't get me wrong, but it is different people with a different smell to them and a different way of handling them. And it's hard for those babies to begin to form attachments. And also, what about mom? She's feeling guilty. She's often isolated, often not with family support. And so for years, it's sort of been a medically positive thing to do. But in terms of relationship and attachment building, it has really harmed those first couple of months for some of these babies. So Yale said, let's try something different. Next slide. As our standard of care. Okay, and they said, why don't we switch away from a totally pharmacological approach, where it's about treating the baby with the methadone or the morphine, keeping the baby in the ICU, waiting for the symptoms of withdrawal to diminish and then disappear in terms of overtly. What if the baby, all of this care didn't happen in the NICU? What if we said that really what the baby needs is his or her mother, that person who gave birth to them? As long as that person is can be safe in terms of interacting with the baby with the help of the nurses around. And they developed a new method that they called Eat, Sleep, and Console. And they kept the mom and the baby in the mom's room. The lighting was lower, the sounds were lower, it wasn't overstimulating, and the mother, with the help of a nurse or nurses assigned to her, could feed the baby on demand, hold the baby, soothe the baby, begin to build that attachment and that bond. And they tried this new Eat, Sleep, Console method with enough of moms and babies that were being born in their hospital that they began to see that the babies didn't need to stay in the hospital for close to a month. The babies were responding to the nurturing care, the on-demand feeding, if medication was needed, but it was being done in that environment. And they found themselves sending moms and babies home in a fraction of the number of days that had been previously their standard practice. And they were doing case management in the hospital. They were talking to their team. They were looking at what is the environment at home for this mom and baby to go home together. Who are the support people? Who are the monitors who are going to be? They assigned case managers. But the whole idea was family-centered care of this relationship. Next slide. Okay, so again, when we were talking about responsive feeding on demand, mom was there and had the help in those days that she was caring for the child in her room. She was learning how to help feed the baby. If she was able to breastfeed, according to what her doctor said, she was learning how to do that. She learned how to swaddle her baby. She learned how to hold her baby when her baby was upset. And she became familiar with what were the drugs that the pharmacology folks were giving to the baby, and were they in fact less severe in terms of what they needed to give to the baby based on the mom and the baby building that attachment. And what Yale started to do was to publish some papers for the field about their data, what they had done, how they had reduced the number of days that babies were staying in the hospital and moms. And they also were talking about the actual cost savings of not having a baby in the NICU for 26 days or a month, and also how moms were learning how to care for their baby in a comfortable environment, and also an environment that was non-judgmental and was there to support them. Next slide. So one of the other things that came out of this study is that there needed to be a change in attitudes and beliefs in terms of the staff that was working with that mom and her baby, because there's a lot of stigma attached to, in our society still, to a mother who used drugs during her pregnancy and thus caused this outcome for her baby. And people were quick, whether it was with their body language or the way they spoke to mothers, to oftentimes give off negative judgmental vibes. And the team picked up on this and said, we need to also train our staff to treat our mothers and that family of origin for that baby with respect. It is not for us to prejudge that mother and what led her to do what she did. Let's start from today and let's build that relationship for the mom and her baby. Let's build confidence in that mother postpartum, explaining this medical situation of her child, but also explaining how important her role is. And even though she may still be feeling guilty and sad about what she did. It's about the future. It's about moving forward, and we can be more possible. The other thing we can do before she and the baby leaves, and this is something we're all familiar with in early intervention, start our case coordination plan, our wraparound services for the baby, the mother, the family, before they are discharged. And we can do that because we've built trust with that mother. We've reduced negative judgmental attitudes towards her. We've taught her how to care for her own child. We've talked about things she should worry about or things that she needs to speak to her pediatrician about. And so when we're sending her and her baby home, in many of these cases, she knows she can rely on us, that we are going to be there for her, and we need to do so. And we in early intervention would be part of that team, because very often in the state of Minnesota, I know this to be true, and also in Florida, we will get referrals for that baby in our early intervention programs. And we need to come to the table with an understanding that we're going to treat the mother and the baby with respect. We're not going to be judgmental, and we're going to be empowering to help assure the safety and well-being of that baby. Next slide. Okay. In many states, and I would believe this is true also in Minnesota, states have made a determination that plans of safe care have to be developed by intervention teams, multidisciplinary teams, around children who are born prenatally drug exposed. And so your state Department of Child Welfare, in Florida we call it Department of Children and Families, we also need to have in the back of our mind, what can we learn about this family? What is the support? What other risk factors may exist in this family? And does this infant meet the criteria for having that family be investigated before that baby goes home? And maybe, in fact, temporarily having that baby be placed with an alternative relative or in foster care. Those assessments, safety assessments, come from our child welfare state authorities so that we can determine if an infant before discharge is safe to go home. Let me give you an example. We would want to know before mom and baby go home, is mom currently on medication herself? Is she on methadone? Is she going to her provider? Is she compliant with her medication? Is she assigned to an NA group? Is she attending? Does she have a family support system to help her? Does she have any co-occurring mental health concerns that are going along with her substance use? And if so, have we not only referred her for those services, but are we able to follow up and make sure that she is being compliant with those services? It's also important to think about whether we have any evidence of domestic violence in that home. If that is in fact the case, if that information has come out about the family, we have to make a determination. Has the domestic violence been dealt with? Has the partner who may be the perpetrator of violence, has that person been removed from the home? Is there an injunction to keep that person from coming back? Are they seeking treatment if it is, in fact, the father of the child? So a lot of assessments are happening and being triaged in that week or so when we have mom and baby together. She's learning about the care. The state is often been notified if there are other risk factors when the intake is done with the mom. And the other important thing is, does this mother want to cooperate? Does this mother want to do what's best for her and her child? and is willing to be compliant with her treatment and everything else that may be provided to her in her case plan. A lot going on because, as I said, safety and well-being for this baby is of utmost concern, not only of the medical professionals, but also of child welfare for the state of Minnesota. Next slide. So some communities have even established systems of transitional housing. So when moms and babies are ready to be discharged from the hospital, in some communities, they have the opportunity to spend a transitional period of time in a supportive housing environment before going back to their actual home. This is where they continue to have both emotional, medical support available to them. It's not hospital care, but it's not being home by yourself yet either. And these are opportunities to help mom engage her family support system, deal with the issues that may be coming at her from other family members who are judging her about what the outcome has been for this baby and about perhaps her period of her life where she's been abusing substances. Home visitation is another great system that many counties have in place, where home visitors go with regularity 2 or 3 times in the beginning to the home where the mom and the baby are living. We do that in early intervention. Maybe some of you do home visitation. We do that in Miami as well. And we learn to work together with our early start nurses and our developmental folks to support the baby and mom and the family at home, and also do what we can to help guide the building of a healthy attachment between the mom and the baby and the siblings and any other family members who safely live in the home. And as we all know, we individualize that kind of care in early intervention. That's why we write our individual family support plans when our babies are under the age of 3. And we individualize them in ways in which we can also have pages of the IFSP where we have what sort of services is the mom getting or the mom and dad getting. If it's a 2-parent or the mom and the mom, 2 parents in the home who are going to care for this child. So this is where our early intervention background comes in, because we know how to work across different disciplines. We know our work is family centered. And now we also know that we can use our home visitation and our care coordination knowledge and skills with these families as we would with any other family, and to meet their needs. Next slide. There is actually Minnesota Statute 125A.27 that says that early intervention services, identification of needs, referrals, screening, and evaluation is needed, assessment, service coordination. These children come under the umbrella of Part C, and it is our obligation to develop individualized family service plans and that are family centered. But it's so important that we come to the table and we realize that the families we're talking about today are more like all the other families that we serve and less different. And so we treat them similarly with best practice that we know is evidence-based. We make determinations about the kinds of therapies and the frequency of therapies that would be needed. We want to engage the family members, particularly the mother, to be a part of guiding and supporting the development of her child. Next slide. So if we had recommendations for those of us in the early intervention field, basically what we would be saying is think about, and I would love for you all to share with me, how long does it usually take for you to get a referral, that an initial screening and then ultimately an assessment is being requested. Are you already dealing with medical professionals, pediatricians? Are you dealing with social workers? Are you seeing these children while they're still in the hospital? Are you seeing them as they are living with relatives? They're back home with mother. What are the different family systems that you're dealing with? I'd be very interested to learn about that. And then what do you think are the core values to engage families in being a part of the development of the IFSP? How do you engage a mother who is feeling this is her fault, who is feeling perhaps she's not far along in her treatment, and so she's sad and she's depressed? How do you become an advocate for her and supporting her and her support system that she comply with and engage in the programs that are she's being referred to? And then, as we all do, we determine what model of early intervention is going to fit this family. Is it going to be better for them if we do home visitation? Do we have the ability in this part of the community to do home visitation and ultimately transition this baby into a center-based program, either part-time or full-time, if the expectation is that mom needs to go back to work or mom needs to go back to school and has limited support in the home? Are you involved with that? We are, and we're involved with our early care providers when those transitions from being at home to being necessarily out of home care. How are we going to determine if that child development program can meet the needs of this baby? So I think these are the qualities you all already have. And I remember the first time I spoke to my contacts at the CDC when the opioid epidemic was beginning. And there was no real literature about that specific population of children. I remember speaking to my colleagues at the CDC, and I said, can you tell us what to do? Those of us in early intervention, these babies are new to us. The drug of choice is new to us. We in Miami had been working with babies who were born cocaine exposed during the cocaine epidemic, but was there something different we should be doing? And the CDC folks were very reassuring. First of all, they didn't have real data yet in terms of these children because they were just starting to be born. But they said, use your best practice of early intervention that you've always used. Use your skills you've always used. Family engagement, family and centered, non-judgmental. Approach these cases that way, and you will learn from them and they will learn from you. And you'll begin from day one to build trust with the families because you realize they are more the same as the families you've always dealt with. Next slide. So what is our role in this process? You know, this whole presentation today is about a specific targeted group of babies, but you collaborate with cross-disciplinary partners the way you've always done. You're still wanting to have families tell you what they need. You don't want to put programs on them. You want to come to that understanding about what's feasible for them, what they would like for their child, and what you can do. And as you make referrals to other agency partners, other providers, make sure the handoffs across agencies are smooth and that parents are treated in respectful ways, and that when you refer them to another agency, you help with that handoff. You make sure that person they're supposed to speak to will be available. What you want to do is eliminate the kinds of frustrations that families face when they're trying to navigate a system they've never navigated before. And remember that if they build trust in you and your team in the relationship with their family, they'll understand how people do this. They'll understand that building a trusting relationship is something they've shown they can do despite the circumstances that they find themselves in. And they will want to build those trusting relationships for their own children. Next slide. Okay. Before we go to our family story, I just wanted to show you what the system of care in Miami, Florida looks like with the integration of early intervention, community providers, working with child welfare. That's working with the Department of Children and Families, working with those folks who make determinations about whether investigations are needed and child removal is needed. This is what our model looks like. Our goal, the goal for child welfare or for anyone else is supporting child well-being, keeping children safe, not putting them in any situation where their safety is threatened, and trying to build strong attachments that assure permanency for that child down the road to the degree that we can when we're part of building their case plans and their case coordination. And what we found in Miami is that we had to tell all the community partners the child-parent relationship is at the core of everything we do. The child is at the core, but the child, remember, there's no such thing as just the baby. We have to assure this family that we're also building family support, and that therapeutic early intervention is going to be at the table and has importance for the successful outcomes for the family and for that baby. And we want to, as we build our relationships with child welfare, when that comes up in a referral for a baby who perhaps is an investigative case, we want to be sure that we keep track of all of our case notes. We know what's going on with the family. If we have any hesitancy as mandated reporters, we do what our state tells us we need to do as early intervention people. And when we started to build all these cogs and they started to go together in a way that people were understanding the language of early intervention, people were understanding that nobody wants this for their child and nobody needs to be treated in punitive ways, adversarial ways. We're all here for the parent-child relationship. And of course, I'm showing the mom and the young child, but we want to build attachment among all the family members and caregivers. It is not in any way exclusionary, but child well-being is our focus. And we are going to have to give opinions based on the facts of what we know and our developmental assessments, maybe in a very new setting. Maybe we'll have to write a report for child welfare, and that may be new to us. And so little by little, we're going to ask our child welfare partners, what do you need from me? And we also need them to understand we have therapeutic relationships with our families. And we don't want those therapeutic relationships based on trust and that we say our truths and we do what we say we're going to do. We don't want them to be broken by other people. And so we let them know that this family is very precious to us. And as we share information and sign consents, etc., we have expectations that you will support and guide the family the way we did. And that is a journey that we've learned over a few decades. And so what I would say is, don't be afraid of being part of a new system. Ask a lot of questions. We have preconceived notions of what the Department of Children and Families, or DIFAS, does to families. So ask questions. And if you have a feeling in your gut that something for your family is being compromised, you need to speak up, because they're relying on you. They trust you. And you can be the glue that guides other providers to live up to the kind of care and nurturing you give your families. Okay. So I think we're going to go to the family story. Am I right, Drake?
Mhm. Great. Thank you, Dr. Katz.
Yeah, that's correct. Yeah.
You're welcome.
I wanted to say thank you for the initial presentation. That was great.
You're welcome. It's what we all do. Everybody
Yeah.
who's on this call now, it's what we do.
It is interesting to watch the evolution through the years. Dr. Katz, I was talking to you about before we started the call.
Yeah.
I feel like at one time the message was, sort of a punishment orientation or
Oh, definitely.
a consequence orientation for mothers, and how we've evolved to more therapeutic and supportive. And it's just I don't have any brilliant thoughts to share about it. It's just sort of food for thought of I think it's progress. And
Yes.
And you have that perspective over time of working across the system.
Yeah. And I think we've also learned a lot about brain development. And we've also learned so much over the last couple of decades about the impact of things on early development and the long lasting impact for good or for evil in terms of young children. And, if our mantra is do no harm, then maybe we finally come to a place today where, as you said, we understand that the family and those attachments are crucial. We're not going to be in our families' lives forever,
Right.
but if we can start them on that path, we can rest easy.
Right. And that attachment relationship is so central, and supporting that as professionals, doing everything we can between that mother and that baby. It's just nice to see our policies and practices change towards putting that at the center, and the family and the child at the center. So yeah, I really appreciate your presentation. Thank you.
Thank you.
Great. Now, Dr. Katz, do you want to present the family story, or shall I, Drake? I can go either way.
Yeah, I think we were planning to have Dr. Katz present. And
Okay,
then,
great,
yeah.
great.
But I hope we can stimulate some conversation
Yeah.
afterwards during the breakouts in terms of what we learned just now. What might we do differently, or what might this resonates with us because this is what we've always done, and we're going to do it for this family as well. Okay, Drake?
Cool. Sounds good. All right.
Pull it up. Okay. Well, I'm giving this the context, of course, the context that I know, which is Miami, Florida, which is a very large metropolis, culturally and linguistically diverse city in Florida. And we're going to be talking about a family with two young children, Nathan, age 6 months, Carolina is 2.5. And they were referred to us to early intervention by child welfare. So in fact, at the time that Nathan was born, prenatally exposed to opioids, they had been in the hospital, and they had been in the traditional setting, Drake, where in fact Nathan had been removed from his mother. The grandmother was an alternative caregiver. They were not using the Yale model of let's keep everybody together. And Carolina was already 2 at the time that Nathan was born. The situation had escalated when the maternal grandmother had called the Department of Children and Families because the children's mother had left the kids with her, and she'd been away for 4 days and no one had heard about the mother. This was a primarily Spanish-speaking family. Maternal grandmother spoke a little English, but basically was a Spanish speaker. And when she called the department to report that the mother was missing and the children were with her, because she was a designated caregiver and mom had not even visited, she did tell, when she made the phone call, she said, "I know mom is still taking painkillers. I'm also afraid because our legal status is questionable we're here in Miami, but we don't have our green cards. We don't have our residency cards. But I want my daughter to be able to have custody of her children. I know the children are with me now because of the removal, but I need help in helping my daughter become compliant with her treatment and her case plan. But this is the situation. She was living in the home with me and the children, and now she hasn't been there in 4 days. Next slide. So as Grandma said, we're just making do. I don't really have, I have like 1 or 2 outfits of clothing for the children. I don't know where to get baby formula for Nathan. I could really, he really would be better in a crib. Carolina and I, she's sleeping in my bed. I'm sleeping on the couch. I need some help. I need a social worker. Somebody needs to help me because for now, I don't think mom is in the picture. And so as the early intervention team, we went to meet the family. We went to their home to meet grandma, and we did our initial outreach, taking with us our team members who were Spanish speakers. Let's go to the next slide. When we got to the home, we noticed that, as grandma had said, she hadn't really gotten sufficient baby formula. Nathan was clearly underweight, failure to thrive. He still wasn't feeding well from the bottle. He was fighting it. Grandmother was pureeing food and putting it in the bottle, hoping to give him something more nutritious, but he was reacting with gas, and his stomach was bothering him. And he was a baby who had very tight muscles. He was very hypertonic, and he couldn't soothe himself, and he was way underweight. Carolina was, she was nonverbal. She really didn't say anything, even to the Spanish-speaking members of the team. She looked very sad in her affect. There were a few toys in the house, but no one on our team could engage her to play, and she didn't make any eye contact. At age 2 already, we started to see that she had a lot of tooth decay in her mouth, probably from still taking a bottle, perhaps, and that bottle, and walking around with the bottle and whatever else was in it. Next slide. So we saw that the grandmother was kind of distrustful. She wondered if we were from INS, if we were there to find out whether the family, what the family immigration status was. She needed so many things in the house. She admitted she was about in her late 60s, that she hadn't taken care of young children in many, many years. And we knew we would need to proceed with caution, but at the same time, we needed to be connected to child welfare to see how they were doing in terms of trying to find mom. Because grandma was adamant, I want my daughter to be healthy so she can raise her children. I am really too old for this. I'm doing it for her now, but you've got to help me. Next slide. So those are some of the challenges we faced. But as I said, the grandmother, she was motivated. She was very sweet with the children. She said, I'll do whatever you need me to do to try to help mom resolve her issues. But I want you to know, if we can't do that, these children are not going into foster care. I'll find a way to raise them. And she talked about how the members of her church had been very supportive and coming over and bringing food for her and the kids, etc. Next slide. So those were what we saw as the strengths. So are we going to do breakout groups? You're going to do that, Drake? Okay, I would just like you all to think about, if you had a case that had some of these similarities, how do you decide, how do you prioritize what you're going to do, and who's going to do what for grandma, outreach to mom, helping the baby, helping Carolina. Do you have cross-disciplinary partners that you already work with to help you engage a family if they're linguistically or culturally different from the members of your team? And what do you think the challenges are going to be if they find mom, if she returns to the home under supervision of child welfare and the grandmother? What do you think the challenges are going to be for grandma, for mom, in working together to raise these children? So you can pick just one of these questions and say, I think this is what we would do. You could share with us what cross-disciplinary providers you already work with. Do you need to add anybody from the medical field to your teams? And how do you think you will support this grandmother? And ultimately, if mom comes back home, how can you continue to focus on the development of the children and them being able to get the early intervention services they need?